All right, thanks, Tim. Good morning. Great talk, Patrick. So, the old man's got to put his readers on. Going bald, can't see. All right, how I open occluded venous stents. These are tough cases. Why do stents occlude? I think we talked about this a lot yesterday. Inflow. They need to be anticoagulated. Even missing a dose can cause stent thrombosis. So like everything, the earlier you get them, the easier they are to reopen. The later you get them, the tougher they are to reopen. And then something super important. So a lot of these folks, these post-thrombotics, they'll occlude and you reopen them, and a couple years later they re-occlude and reopen them. And every time this happens, they start losing what I call inflow real estate. They bag some collaterals, profunda that may have been okay is not as okay. So every time they occlude, the chances of maintaining these stents open long term reduces. So you got to really educate your patients on all this, and your referrers. I'm having a colonoscopy in 2 days. They want to stop my apixaban for a week. No. If you got to have conversations with these GI guys. I usually tell them, listen, you may not find a polyp. So why don't you just leave them anticoagulated? If you have nothing, then good. But if you have a polyp, then we'll talk about it and go back and do it later, something like that. So anticoagulation is important. Inflow is important. There's this new thing out there. We don't really see it, but folks talking about, the bioengineers, how a stent in a vein causes this compliance mismatch, and it may, go on to affect the inflow or outflow and cause stent occlusion, or at least in-stent restenosis. This really is not clear. I just kind of point it out to you. We use duplex to identify stent patency and follow them, and usually when there's a stent occlusion, we will see it by duplex. Some of these folks, that's Piper out there, our little dog crying. Little Frenchie. Some of these folks will occlude their stents, and they've got such collateral buildup that they'll do okay, and others you occlude the stent, and they're acutely problematic with severe symptoms. So here's what I kind of want to get to. Here's a stent with a stent occlusion, and you see all the thrombus and patent lumen and thrombus. This is somebody who, if you start looking here, they've been relined a couple of times. This is actually a Raju patient that came to me after 30 years. They already had a stack like this when I inherited them. But you see, it's probably been relined 2 or 3 times. So every time that happens, you lose intraluminal real estate. So you reline somebody 2 or a 3rd time, this is all you got to work with. So I don't know what that is. That's probably 80 millimeters squared in area, or 70. And then as you start working on them, you've reopened them. Here's your run, and you see there's all the intraluminal space that's been lost with relining because you can't get the thrombus out. So balloon hyperinflation, the only tool that we had, you cross it, you wire it, you start stretching the balloon, and that's it. And plus or minus relining it. Now we have a new device I'm going to talk about, and look how much intraluminal real estate now we've gotten at the inflow. The only thing I could do here is a small conquest balloon to try and get this open. I'm all jammed up. I can't extend it any further, so the profunda would be here, the femoral would be here. So these can get tough, especially after multiple occlusions. This patient is an MD, JD, a doctor and lawyer, real good guy, but he's been struggling with this. So here's his final, we got some lumen restoration. This is before the RevCore device I'm going to talk about. So balloon hyperinflation is not enough. And then some of these require sharp recanalization. There's a new Liberty device that's steerable, which is helpful. So now the Calipinto needles, the Roshishita needles that are very stiff rods, I mean, they're weapons. This is easier to manipulate in the stent. And the one nice thing about sharp recant of stents is you do have a roadmap to work with. Still, you can be outside and not know it if you're only working AP. So as we always emphasize, with all these chronic total occlusions, that gantry's got to be spinning back and forth, getting you multiple angles, because in one view you may look like you're intraluminal, in another view you're clearly out. So always be spinning that gantry. This wire came across to me, sorry, I think is her name, but this thing's magic for crossing stents. You go up, it builds a loop, and you just push the loop, and it's really made crossing easier. We published our first couple of cases with this new device called the RevCore, it's our vascular research fellow. And this is what it is. I mean, I've been waiting for something like this for years, an aggressive stent cleaner. And it's really well engineered, has you can actuate the metal basket, you know, from small to big, and then this little wheel, you just keep rotating it as you go up and down. It's kind of neat because it feels soft and the edges are smooth, so it won't catch on stent struts. It's designed for cleaning stents. You can use it in native vessels too, but more for stents. So it's kind of rough, but kind of gently rough. I mean, it sounds a weird term, but once you start using it. So this is a case, this stent's been occluded for 15 years. She came from the Cayman Islands. They tried to reopen it several times down there, and she was progressing. Her lipodermatosclerosis is getting worse and worse. So she came, these are the cases that I get. So she came up, and here what I want to point out, so here's the occlusion. And these are tough because there's always a cap here that you have to get through. You have to have this Protrieve funnel, also by Inari. It's a wire mesh that'll trap all these emboli that you're going to send up. A filter won't do it. You got to have this thing. It's 20-something French, comes down from the neck. You got to be careful putting it down, especially with residents and fellows. That wire's got to be through the heart. And I'm there like a freaking madman watching that, you know, the gantry, watching that thing come down. So that's wire's got to be straight. You got to visualize every step coming through the heart to make sure that the wire's in the cava and you're not curled in the ventricle, because you can easily do something bad to the heart. Here's the basket inside, and then we're just kind of rev it up and down. You can see how we've gotten the thrombus out, so you don't see that residual chronic thrombus on the wall that you would with balloon hyperinflation, and here's the run. Another case similar, this is a young girl, multiple occlusions, terrible inflow. She was animate that she wanted a reintervention, and we got her open with the RevCore. You see that there's no thrombus on the wall of the stent now, a bunch of stuff that we got out of it. And here's the Protrieve funnel. That's what all trapped in the funnel. But on her, she went down because I couldn't get the access low enough, and I left some thrombus between the profunda and the stent as she went down because of this little junk right here that I couldn't get her access properly. And then this is from, I'll go quick, a week ago, a patient of mine that looks like the first stent, I did the right side back in 2005, and he did well for about 10 years. And then we had to do a left, and then he started going down from inflow problems and multiple revisions on both sides. So here's what I'm talking about. You got to get access low, so you can see the entire femoral vein confluence. Here's a profunda, here's a collateral, and then the job is getting through this cap here. We crossed them. The left, the inflow was poor, so I just left this one down. You see it's being relined, and there's a separation from chronic thrombus that I couldn't get out with hyperinflation before. And here it is at the chronic thrombus and the loss of intraluminal real estate from relining. So we got him squared away, ballooned. You develop a track first, with about an 8 balloon, and then you can introduce the RevCore device and go up and down. So here's all the stuff we got out. We had the ProTrieve in there. This is another case. I just didn't have one, but you see the funnel, so it catches everything going north. And then in this guy, it looks like we stacked some thrombus here and here. So it required suction thrombectomy. Since the Inari people were with me, we just had this, and we're able to clean it out. And here's the final on the right. All right, so that's how I do occluded venous stents. Thank you.